Nigeria has been on the executive board of the World Health Organization for 4 years now, which I'll be leaving at the end of the present World Health Assembly. So indeed, what it means is that all the draft resolutions that the executive board is bringing to the ministers to approve had Nigerian input. And so, to that extent, we are part of what is happening here. But specifically, there are some specific areas that Nigeria championed. Take, for instance, the mechanism on spurious, substandard, and adulterated drugs. We sponsored that resolution, even though it took us almost 3 years to get it eventually passed, because many countries considered it quite controversial, but we was eventually able to negotiate and eventually had it passed. Then, of course, in the response to the DG's address, we made certain input, which I think will be taken very seriously. We reaffirmed the African position on the post-2015 Millennium Development, not 2015 global agenda, what has been described as the Sustainable Development Goals. And we're in agreement with the rest of Africa that the unfinished business of the MDGs, particularly the health-related MDGs, goals 4, 5, and 6, should continue post-2015. We're in agreement with the rest of Africa that universal health coverage should be a core component of the post-2015 agenda. We also in agreement that the non-communicable diseases this time around should be included and play a very significant role.
Okay, let me quickly take you back to the issue of the health-related Millennium Development Goals. Where exactly is Nigeria now?
Well, take for instance the issue of child mortality, infant mortality. We think we're on track for Goal 4. Because if we extrapolate,
Goal 4 is?
Goal 4 has to do with child mortality, child health. But the key index there are two key indices. Infant mortality has to do with those 1 year and below, and then the under 5 mortality rate. In 2008, the National Demographic and Health Survey gave, for instance, the under 5 mortality rate to be 157 per 1,000. 157 per 1,000 beds. And then gave also the that's the infant mortality, those below the age of 1, at 75 per 1,000 live beds. But in 2012, the National Bureau of Statistics, which has the mandate for statistics in Nigeria, working with the Office of the Senior Special Assistant to Mr. President on MDGs, conducted a survey, at least not waiting to the end of the Millennium Development Goals target before see whether we're on track or not. And the national survey shows some improvement. The under 5 mortality ratio fell from 157 per 1,000 to 94. While the other one didn't fall so well, but at least some progress that's the under 1 mortality rate fell from 75 to 64. So there is.
We're supposed to be at 30.
Yeah, because you're talking of 2/3 reduction starting from 1990. So we're getting close. And
so what's happening with maternal mortality?
Maternal, yes, that's where we have some problem. We're not quite on track, except if we're able, as we are projecting, to really accelerate.
Why shouldn't we be on track?
Oh, well, it's for Nigeria, it's a bit complex, and I'll explain why. We are running a federation. Even though health wasn't quite spelled out in our current constitution where it should belong, whether on the exclusive legislative list or the concurrent, but from tradition and from what we had in the 1979 constitution, it is concurrent. And in practice, it is concurrent. States have a right to make laws as far as health is concerned, except when it relates to drugs and then the federal government can also make laws. Now, the states have their own ministries of health. They have their own priorities. And it's not often easy for the Minister of Health coming from the federal government to enforce certain things because they have a right to run their system. So coordination has been a big issue. When we disaggregate data, you actually find that some states actually have already achieved the Millennium Development Goals as far as MDG 5 is concerned. To be honest, for instance, Ondo State has already achieved it. There are states like that. But majority of the states have not. And there are states, because we're talking about national average, when I say that even now it has gone down to 250 per 100,000, that is high. But that is national average.
Very high.
That is high, not very high compared to the rest of the world. It is high. Because there are also countries that are
in
worse
other
off.
countries, you still have like 6 dying out of 1,000.
No, those are the very advanced countries. Yes. But if you put countries that are par with Nigeria,
shouldn't we aspire to be?
That's why I say it is high. Okay. It is high because it's all relative talk. Certainly, even if one woman dies because she's giving birth, it is a disaster. But we're talking relatively, since no country has zero. It is high. There's very high, but some states are actually very high. Because if this is national average, it means some states still have as high, and indeed that is true.
Lagos
still have as high as 800, 900.
Over 500.
Lagos State is not up to 800, but they are in that region. But there are states with up to 800, 900 in some of the zones.
So what are we doing wrong? Yes, you said we are not coordinating well.
Well, I wouldn't say what we are doing wrong, but what are we not doing?
Okay.
Because wrong connotes that you see what is right and you are not doing it. There are challenges, even for states. Sometimes we are pushing hard, but it doesn't mean they are not doing their best, but they don't just have it.
What are the challenges?
Take, for instance, human resources for health. Take, for instance, the Northeast states. Their own situation is even further compounded by the fact that some other Nigerians who were willing to work in that part of the country now are living in droves because of the security challenges. So even their own situation is getting worse. Even at the time they had some of these Nigerians working there, they still didn't have the adequate number of human resources for health. The states that don't have the security challenges, their major problem also has to do with capacity. Capacity in terms of who pays for health. If you don't have health insurance scheme for your people, they'll have problems. Even in some of the states that don't even have the security issues, they still have issues with the capacity for human resources. They don't have enough. Probably only Lagos may have reasonable ratio because it's very cosmopolitan. People want to stay in Lagos and work. And then, of course, the FCT gradually is also building that. But most other states in the country, whether you are in the security challenge zones or you are not, have issues with having enough nurses, enough doctors, enough midwives, enough laboratory scientists.
Okay, so that brings
that's a problem
to the issue of universal health coverage.
Yeah.
Perhaps if this is fully in place, some of these issues that we're talking about will not be there.
Well, it takes time. I don't know whether you listen to the Secretary of Health and Human Services of the United States of America. He says, yes, USA is also struggling to achieve universal health coverage. Because that's one area, even though they are developed, they didn't quite achieve. And that's part of what their president aims to achieve before he leaves office, even though he has a lot of opposition. In Nigeria, the president has hosted a summit on universal health coverage and declarations were made. It's not automatic, but we have started the journey. Now, government comes out with a pronouncement that the destination is to make it 100% coverage for Nigerians. What we had, unfortunately, many Nigerians never understood, many stakeholders, I keep explaining it even on the media and so on. The National Health Insurance Act, the Act governing National Health Insurance Scheme, says it is voluntary. So indeed, if you have not on your own decided to go and buy health insurance, you are not falling foul of the law, but you cannot turn and blame government because the law says it's voluntary. So by today's law, the government cannot compel citizens to buy health insurance. It is if you wish, even government cannot even enforce health insurance.
Perhaps I don't even understand it. So you want to quickly explain to us what it means to buy health insurance?
What it means to buy health insurance is that first you must have the desire that you're going to contribute to a common pool. Now, the way it works is that if 100 people decide, to contribute to a pool and say to themselves, we're contributing this, in the event that any of us has a problem, you take the money from there. Now, not everybody will be sick at the same time. Illness does not come, except where you have an epidemic, but outside epidemics, illness will never come to a community members at the same time. Therefore, when people contribute to such fund, some people may never even be ill for the whole of that year. But it's pooled money, so everybody contributes a little, but when you pool, it is such large source of funding. And maybe 2 or 3 out of the 100 become sick, they will have access to it. That is just the simplest way to describe health insurance. In the context of Nigeria, how can you buy health insurance? You can buy from government agency, which is the National Health Insurance Scheme. But you can also buy from private. There are private insurance companies that actually run health insurance schemes. But of course, the private ones are more expensive than the government one, because government is purely social health insurance. For the community-based, how does it function? I'm sure people are familiar with many communities that have town unions. So the whole idea is to form what we call a mutual association. We help you through the National Health Insurance Scheme to provide you free of charge the technical ability. It's just for either state governments, local governments, or even community leaders, indicating to the National Health Insurance that they wish to form a mutual association, and can you come and assist us technically to do so and set it up. Now,
so what would be the benefits?
It's so easy. The thing is run by the community. The same way they choose those that are their town union leaders, the same way the people who are willing to collaborate will choose the leaders who will manage it. Now, they pay. Now, I'll give you instances. In some communities, they are paying as low as 150 naira per month. In some others, they are paying 100 naira per month. But that will cover your spouse and 4 children. For basic health care, when you have fever, when your child has diarrhea, is coughing, you will get attention at health facilities. So it is something some communities are already enjoying in Nigeria, but it has not gone to the scale we had wished it to have.
More people to come on board.
So we need to do more marketing, we need to spread the word even the more.
Okay, so as we wind down now, what do you think Nigeria is going to be bringing to the table as a success story at the next World Health Assembly meeting?
Well, first of all, there are programs that we are running. We think now that all of us are agreed in Nigeria, this year should be the year of polio interruption in Nigeria. By the next World Health Assembly, I want the Minister of Nigeria to walk tall and come to Geneva in May next year and say, look, we have interrupted polio transmission in Nigeria. That will be very remarkable. I would like a situation where Nigeria will come and show that we're doing very well in terms of the universal health coverage. We want to see a situation where Nigeria, working along with other countries, continue to reinforce the issue of regulation, the issue of fake drugs and so on is still a major problem in many countries. Nigeria is not doing too badly, but we can do much better still. But we need to work with others. We want a situation where Nigeria will come and say, yes, more and more of our pharmaceutical companies have now gained WHO good manufacturing practice certificates. Our products are WHO pre-qualified. I want a situation where we can say, yes, all those new vaccines that Nigeria had planned to introduce later this year and also next year, indeed, we have introduced them. And what are they? The PCV, which is the pneumococcal conjugate vaccine that will help prevent pneumonia, another killer of children, we want to introduce later this year. And then next year, we have already programmed it to introduce the rotavirus, which is again against childhood diarrhea. We want that kind of situation. And then, of course, this draft resolution that we are sponsoring, we think that it should be able to scale through the executive board of the WHO. And by this time next year, it should be on the table of the World Health Assembly for debate and passage. And we expect that that resolution will be passed next year, so that universal health coverage can then be total, because we can't discuss universal health coverage without surgery, without safe anesthesia.
I wish you all the best.
Thank you very much.
Thank you so much.
Thank you.
how we wrap up the show for this week. Share your thoughts on health news at channelstv.com and other platforms showing on your screen. From Geneva, Switzerland, the location of the 67th World Health Assembly meeting, I'm Yomi Otaigbe, thanking you for watching.